Okay, good afternoon. Thank you so much for having me. I hope everyone can hear me and that you can see the slides. I see there's already a hand raised. I'm not sure if that is on purpose. Joseph? Oh, several hands raised. Is there a problem? Can someone just let me know if you can see the slides and if you can hear me?
No, we can hear you very well,
Okay.
and we can see you fine. I think Joseph might have just mistakenly put his hand up, so don't worry about it.
No
I
problem.
think you can ask him at the end as well.
No problem. Thanks so much.
Thanks.
Thank you for joining this afternoon and for giving me the opportunity to do a ART guideline update. As you heard, my area of focus is pediatrics, so I'm going to try to throw as much peds in as well. Unfortunately, I haven't included PMTCT because of time pressure, so hopefully we'll have another opportunity to go through the PMTCT guidelines. So what we're going to do today is quickly try and go through the updates as part of the new National Consolidated Guidelines for the Management of HIV. So we're going to start at the beginning, and the first place we're going to start obviously is with ART initiation. And the first question is, who do we initiate? And thankfully, for several years now, anybody who tests positive for HIV is eligible for ART initiation. The next question is, when do we start them? So that's determining the time frame. So when we've diagnosed a patient positive, we need to do a thorough clinical evaluation as well as some baseline laboratory investigations. And based on your clinical assessment, you're going to divide your patient or split your patients into one of two groups. The one is the asymptomatic patient who's clinically well. They should start their ARVs as soon as possible. And there's a big push to do same-day initiations or SDIs. I'm sure you guys have been aware of that. And that's to try and make sure we retain them in care, because we used to see quite a massive drop-off of patients once they tested positive that never came back to start their ART. And what's important here, so this is different to our old guidelines, and to remember that the laboratory results, we don't need to have them available, and we won't in most cases, but that the patient should be contactable if the results do come back as abnormal. So our asymptomatic well patients should really, as far as possible, be started on the same day. And if not the same day, then as soon as possible and within 1 week. The second group is if they have advanced disease. So these are symptomatic patients or patients that you may know have a low CD4 count. And these patients might require further investigation for their conditions. And the guideline does provide quite a clear table of which medical conditions would cause one to defer ART initiation. So I've included the table here. I'll try to go through as quickly as possible. Anyone with TB symptoms. So in those patients, you wouldn't want to initiate ART before you've investigated and either excluded or confirmed TB. If TB has been excluded, then you would initiate your ART. If you diagnose TB, it would then depend if it's drug-sensitive TB and then also on the location and the CD4 count of the patient. So if you have drug-sensitive TB in a non-neurological site, you're going to defer ART and start TB treatment. If the CD4 count is less than 50, you're going to initiate ART within 2 weeks. If the CD4 count is more than 50 in adults and adolescents, you're going to initiate ART after 8 weeks of starting their TB treatment. So they will actually be through of their or completed their intensive phase of TB treatment. In infants and children, they leave quite a big variation. They say from 2 to 8 weeks. In my consultations with Dr. Gary Rubinson, who's a pediatric infectious disease specialist, we usually initiate them after 2 weeks. If you have drug-resistant TB at a non-neurological site, then you're going to initiate ART after 2 weeks, irrespective of the CD4 count. And if you have any TB, whether it's drug-sensitive or resistant in a neurological site, you want to defer ART until 4 to 8 weeks after starting TB treatment, because these patients are at risk of an iris, which can be very severe or fatal. If your clinical evaluation shows you signs and symptoms of meningitis, those types of patients you wouldn't want to initiate ART on. If you have a patient who is CRAG positive, then you would defer ART, provided they've got no signs of meningitis, so their LP was negative. You would initiate their fluconazole for 2 weeks. I'm actually going to discuss the new cryptococcal guidelines at the end of the talk. And then you would initiate your ART. With confirmed cryptococcal meningitis, you need to wait for 4 to 6 weeks before you initiate your ART again for risk of iris. If you have an acutely ill patient, whether they've perhaps got a PJP or a bacterial pneumonia, you may want to treat that first for a week or 2 before we initiate their ART. And if on clinical examination, it looks like there are signs of liver disease, you wouldn't want to initiate necessarily on the same day, but rather confirm with an ALT and bilirubin and then investigate further as needed. Other reasons for perhaps delaying ART would be if the patient isn't ready to start or if you have serious adherence concerns, but we really need to weigh up the pros and cons. So your concerns about adherence need to be severe enough to outweigh the risk of the HIV disease progression. And obviously these clinical indications that we've just discussed would be a reason to defer ART initiation. This isn't new, it isn't an update, but for some reason we tend to do it badly. So I just wanted to highlight the importance of the baseline clinical evaluation. So we really need to assess for any danger signs. A nutritional assessment is really important. There's been more and more focus on this as the program has progressed. Screening for TB and symptoms of meningitis. Obviously, this is because we may need to defer ART initiation. Mental health screening. So we're really looking for active depression and substance abuse. I think we woefully underdiagnose depression or anxiety disorders in our patients. And these have, massive impacts on adherence and quality of life. Screening for NICD, so diabetes, hypertension, epilepsy, bearing in mind that so anti-epileptics have got drug interactions with our ARVs, and diabetes is the second leading killer after tuberculosis. So it's really important to manage this in our patients. Screening for pregnancy, so that's important because we want to prevent mother-to-child transmission, and the guidelines are different. And also to assess fertility desires. So this seems to have become a big focus because of the concerns with dolutegravir in pregnancy, which I'm also going to talk about later. But it's really an integral part of managing all patients, whether they're HIV infected or not, to prevent unplanned or unwanted pregnancies. Screening for STIs, logically, because HIV is also a sexually transmitted infection in most cases. Neurodevelopmental screening in children, and lastly, the WHO clinical staging. This is straight out of the guidelines. So what are our baseline laboratory evaluations? So the first one is a confirmatory test. So everyone needs to have 2 positive tests. In the adults and adolescents, that's really easy because it would just be 2 rapid tests. However, in young children, which I haven't included in this slide, I'm sure we're all aware that babies get antibodies from their moms. And so children under the age of 18 months, when we screen them, we do a HIV PCR test. If that is positive, we then confirm with another HIV PCR. Children who are older than 2 are managed the same as adults. So they would be screened with an antibody test, a rapid test, and also confirmed with a rapid test. But in the new guidelines, we have a bit of a gray area between 18 months and 2 years. And in those cases, a small number of children might still have antibodies from their mom. So we screen them with a rapid test. And if the rapid test is positive, we would initiate them and do a confirmatory PCR, just between that age group of 18 months to 2 years. All of our patients get a baseline CD4 count. Patients who are initiating on TDF, that would be all our adult and adolescent patients generally, they would require creatinine to have a look at their EGFR. And it may be, definitely worth considering doing a hemoglobin. It's most important if we are starting a patient on an AZT regimen, but a lot of our patients may have anemia, iron deficiency, or anemia of chronic disorders. Gene experts. So Gene Expert we do for patients who screen positive for TB symptoms, but what is new in this guideline, and again, I'm going to touch on it later, is that it's different in pregnant women. So all pregnant women who are HIV infected need to have a Gene Expert done, whether they're on treatment or not. And that's just because of the low sensitivity of our TB screening in pregnant patients. The CRAG tests, that's a reflex test done usually by the laboratory if the CD4 count is less than 100. But if for some reason you have a patient with a low CD4 count and it hasn't been done, maybe there was a lab error, please make sure that you request it. Another evaluation that I think we really overlook is the cervical screening. So all HIV positive women, provided they have had their sexual debut, should have a pap smear done, and it should be done every 3 years, provided their pap smears are normal. And then the hepatitis B surface antigen is to identify those who are co-infected with hepatitis B. This is most important when you are actually switching patients and taking a patient off of TDF. So what else has changed is that we no longer do baseline cholesterol and triglycerides for patients who are starting on lopinavir/ritonavir. This is only done at 3 months, which we'll discuss a bit later. And that ALT is not a baseline blood. It's only done if it's clinically indicated. So if patients are jaundiced or have other signs suggestive of liver disease. So it's actually a lot fewer than what one might think. It's basically a CD4 count, a creatinine, and an HB. How do we assess the renal function? So I'm sure this is familiar to all of you. What has changed now with the guidelines is that we are starting to use TDF at a younger age. So we now use TDF from 10 years of age, provided that they're more than 35 kilos. And the lab, unfortunately, won't calculate the EGFR using the MDRD equation for you. So between the ages of 10 to 16, you need to calculate it using the Conahan-Barrett formula, which is on the right there. And that is the height in centimeters times 40 divided by the creatinine, and that'll give you your EGFR. And it needs to be more than 80 to use TDF in these patients. The lab will provide you with a EGFR if patients are older than 18. So again, there's a little bit of this window period between 16 and 18 years. And if you don't get a result from the lab, which you won't, you can use, if you just Google MDRD, there are many formulas available on your phone, or it's available on the website that I've just included at the bottom. And there, the EGFR needs to be more than 50. I don't believe this has changed. For pregnant women, we don't rely on the EGFR, but the absolute creatinine level, which needs to be less than 85. So now we know who we start and when we start them, but now we need to talk about what do we start them on. So this is a summary of the first line regimens in the new guidelines. So almost everything is new. So in the previous guidelines, neonates weren't really included other than it said to consult an expert. So now we do have guidance on managing neonates, and provided they're more than 2.5 kgs, these patients would be started on a regimen of AZT, 3TC, and nevirapine, purely because we have no other options for them. So it's basically functions as a holding regimen until we can get them onto a definitive regimen, which would be a PI-based regimen. Why we can't use lopinavir/ritonavir is because children, and it's very toxic to children under the age of 2 weeks. And also if they're less than 42 weeks corrected gestational age. So by that, I mean, if a baby was born prematurely, let's say at 36 weeks, you'd have to wait 4 weeks for baby to be term, and then the additional 2 weeks. So it would be 6 weeks before this baby could actually get lopinavir/ritonavir. As soon as these babies are more than 4 weeks of age and 42 weeks corrected gestational age, and they're more than 3 kilograms, that's when they would be switched to the abacavir 3TC lopinavir/ritonavir. You don't need a viral load at this point in time. The neonatal regimen is quite possibly not going to suppress the viral load, but unfortunately we can't use the PI, as I've mentioned, and we can't use ABC. It's actually not registered under 3 months of age. but in our guidelines, we do use them from 1 month, and we don't seem to have had any problems. This has also changed. So anyone who's familiar with the previous guidelines for children will know that the regimens were decided based on the age and weight of the patient. So if patients were more than 3 years of age and more than 10 kilos, they were started on a back of a 3TC and efavirenz. If they were less than 3 years of age or less than 10 kilograms, they were started on a back of a 3TC and lopinavir ritonavir. So you'll notice that efavirenz has basically fallen away from the pediatric regimens. And that's largely due to our PMTCT program, most likely. So our PMTCT program has been incredibly successful, but unfortunately, the daily nevirapine does cause cross-resistance to efavirenz. So the data is quite clear that the lopinavir ritonavir is just a better regimen for them. And we've been using daily nevirapine since 2010, and those mutations tend to stick around for quite a long time. So that's what's new in peds. Where I would still consider an efavirenz-based regimen is if you have a pediatric patient who is also taking TB treatment and you're now initiating ARVs. That's just because of the drug interactions. It's a lot more complicated with lopinavir ritonavir than it would be with an efavirenz-based regimen. So the next thing that's new is that we're now starting to introduce dolutegravir. I like to still call it the new kid on the block. I don't know if we all still consider it that, because it feels like it's been around for a while. But basically, any child of any age, provided they're more than 20 kilograms, would be started on a back of a 3TC and dolutegravir. And then as soon as they're older than 10 years and older than 35 kilos, we're then looking at our adult regimens, which is traditionally TDF, 3TC, and dolutegravir most likely. So I'd like to spend some more time, and I'm sure you guys are tired of this, but just talking a bit more about dolutegravir and some of the new data that's also become available. So I'm sure you've all seen these slides before, but basically just highlighting why we're so excited about DTG. And the fact is just that TDF, 3TC, and dolutegravir is a really potent ART regimen, which is really exciting. So previously, with our previous guidelines, where we were comparing TEE, so tenofovir, emtricitabine, efavirenz, it was a once daily tablet, easy to take, but really poor genetic barrier to resistance. So it was easy to take, but it was easy to fail. And then we have our second line regimen, which was AZT, 3TC, Eluvia, which was 5 tablets, it's taken twice a day, lots of toxicities, lots of drug interactions. So it was very difficult to take, but it had a very high barrier to resistance. So our first line was easy to take, easy to fail. And our second line was difficult to take, but difficult to fail. And now we have a regimen in our first line, which is actually easy to take and difficult to fail, which is really just the perfect combination. It's far superior at dropping the viral load. It really causes very rapid viral suppression. I have a pregnant patient, well, not pregnant, she's a breastfeeding patient who in 1 month on TLD took her viral load from 120,000 copies to 37. And one of the nurses phoned me saying it must be a lab mistake, okay? But it just highlights how effective it really is. It's very well tolerated when compared to efavirenz. We've spoken about its barrier to resistance. And it doesn't have any drug interactions with contraception, which is what we see with our efavirenz-based regimens. It renders our hormonal contraception less effective. And then we end up with unplanned pregnancies or unwanted babies, which is something really best avoided. DTG is an integrase strand transfer inhibitor, so it falls in the same class as raltegravir or bictegravir. The standard dose that we have available is 50 milligrams daily. Why is that important? Well, that's why we can only use it from 20 kilograms. So in time, I'm sure we'll have different formulations, and that weight restriction will actually change. The weight is purely limited to the current formulation that we have available. When we look at it in fixed dose combination with tenofovir and 3TC, we can only use it from 10 years of age and from 35 kilos. That's got nothing to do with the DTG, but purely the tenofovir. Those are the restrictions for using tenofovir. Unfortunately, there are some interactions with rifampicin. Rifampicin tends to cause lots of trouble with our ARVs. So it's really important if you're treating co-infected patients that you know how to manage these interactions, because it's probably one of the biggest reasons why we get rapid development of resistance, especially to our PIs. And how we manage that if they're on DTG is to add an additional dose 12 hours later. So they would take their TLD, let's say in the evening, and in the morning they would take a single dose of DTG, or vice versa. And the other option is that if a patient, let's just say a newly diagnosed patient, you confirm TB, so you've started TB treatment, now 2 weeks later you're initiating your ART, it's really worth considering an efavirenz-based regimen, because efavirenz doesn't have these interactions with rifampicin. And then once they've completed their treatment, then convert them to a DTG-based regimen. These are the different manufacturers, and I've come across almost all of these in the different clinics, and they do look quite different. The bottles are very different. Even the tablets can be different colors. And this is very distressing to patients and very confusing. So please take the time to explain to them that what you're giving them is actually the same as what they've had before, because they'll go home and just not take it if they're too nervous. And for some reason, patients are far too scared to ask us any questions. I'm not sure why, but they keep their side effects and their fears to themselves. So please explain to them. I spent about 15 minutes with an elderly lady the other day, and I simply couldn't convince her. So I had to go scrummage around to go find the bottle that she wanted. So just to be aware of explaining that these are all the same. When this slide was made, and when we all had the TLD training last year, I hope everyone was part of that, there were these concerns raised about the potential risks of neural tube defects in babies born to women who had dolutegravir exposure in the periconception period. And based on that, the guidelines currently recommend that you should be cautious in using DTG in women who are actively wanting to conceive, in women who are not on reliable contraception, and women in the first 6 weeks of pregnancy. So note, it says be cautious, not that it's contraindicated. Okay. And it's recommended that women of childbearing potential that don't actively wish to become pregnant should be on contraception. But that's just good practice in general. I think regardless of DTG, as I mentioned earlier, I'm glad we're really focusing on fertility desires, but this is something we should be actively seeking out regardless of DTG or HIV status. And it's really important, and I feel like this is where perhaps we've failed, is to respect a woman's autonomy in decision-making about their health and to enable them to make informed choices. So based on that, this was the guidance that was given, is basically if you have a woman or an adolescent girl who is of childbearing potential, if they were not of childbearing potential, then you could go straight to TLD. That's what was recommended. But if they were of childbearing potential, you needed to engage with them and establish if they were pregnant, if they were planning to fall pregnant, to discuss the benefits and risks of dolutegravir and efavirenz, and then to allow them to make a choice. One may be inclined in those in early pregnancy, well, this was the guidance at the time, in early pregnancy or women actively wanting to conceive, one may be inclined to lean more towards TEE. If the woman was not pregnant and had no intention of having a baby anytime soon, then one would potentially err more towards the TLD option. So how do we enable clients to make an informed choice? We need to make sure we understand the current pregnancy status and the fertility intentions. We need to explain the risks and benefits of both options. And then we need to discuss and provide options for contraception. And I think step 2 is really important. I think some clinicians choose to make the decision on behalf of the patient. So let's have a look at some of the risks and the benefits. With regards to DTG, I mean, we've already touched on the benefits. It provides rapid viral suppression, sometimes within 4 weeks, which really has massive benefits, especially in pregnant and breastfeeding women, because it really, gets that viral load down really quickly. It also prevents risk of transmission to partners because the viral load has come down. It preserves the patient's immune system the quicker we get that viral load down. So it really is quite a significant benefit. It's got a high barrier to resistance, which is, much better than what we've seen with efavirenz. Doesn't interact with the hormonal contraceptions, and it's just much better tolerated. If you look at all the studies, all the data, it really was just superior to an efavirenz-based regimen. So what were we worried about at the time? I mean, no drug has only good and no bad. And again, there was this concern about neural tube defects. So that made people very nervous, and no one wanted to give this drug to women, which was very sad because it really is performs so much better than efavirenz did. And it does have drug interactions. So rifampicin, which we've discussed briefly, metformin, some of the anticonvulsants, and the polyvalent cations. I'll touch on all of these shortly. Efavirenz. So what are the benefits? Well, it's been around for a long time, and we know that it's safe in pregnancy, and it doesn't have a significant interaction with TB. But what are the risks of using efavirenz? It has a low genetic barrier to resistance. And not only that, our population has a baseline NNRTI resistance of about 15%, which is one of the big drivers as to why we had to change our first-line regimen. So more than 1 in 10 patients that you give efavirenz to, it's not going to work because they already have resistance to efavirenz. It has drug interactions with contraceptives, and not only does it have neuropsychiatric side effects, but it has a variety of other side effects as well. So we now have some new data about the neural tube defects. So I'd like to just share some of this with you. Unfortunately, due to time constraints, I can't spend too long on it, but it's called the CPD study. And basically, this is the same study that raised the flag initially a few years ago. So what they're doing is it's a surveillance study looking at birth outcomes at government maternity sites in Botswana, and it's been running since August 2014. And its primary aim is evaluating neural tube defect prevalence associated with ARV exposure at conception. So in May 2018, there was an unplanned analysis, and there was some concern because there appeared to be an increased prevalence of neural tube defects seen in the women who were exposed to DTG versus non-DTG art. And those differences was a 0.94% to 0.12. So basically what that boils down to is we're looking at 9 in 1,000. So 9 babies out of 1,000 pregnancies had a neural tube defect versus 1. So that was quite significant. And that was around the time we started making our guidelines, which is why there was all this information put in about counseling and making sure we let women make informed decisions. They continued analyzing the data from May 2018 through to April 2019, and they saw a lower neural tube prevalence. So here the comparison is now 0.3% versus 0.1%, with a prevalence difference of 0.2%. Sorry, so it had significantly changed once they'd collected more data. And now we're going to look at what the data shows us coming through to April of 2020. So this is just a diagram expressing what we've just discussed. And when they looked at the data from April 2019 through to April 2020, we can see that there's been a continued decline in the prevalence of neural tube defects. And now so you remember we started at 0.94, it then came down to 0.3, and now we're looking at 0.19%. So what does that mean to us? So the current analysis, as of the 30th of April 2020, we're now comparing 0.19% versus 0.11% with a prevalence difference of 0.09%. So when we look at counseling our patients in terms of the risks and benefits of dolutegravir versus efavirenz, just bear in mind that the potential increased risk, there's always a potential increased risk, is actually much lower than we initially anticipated when you compare the two arms. And the prevalence difference is now only 0.09%. So now we need to take that into careful consideration when we're weighing up the risks and the benefits when we counsel these patients. And ultimately, the woman should choose. In my practice, I honestly prescribe TLD to all my patients. Oh dear, and now my slides won't move. Okay. So that's my just quick update about the neural tube defects. And I'm fairly certain that in time, we're going to see an update in our guidelines. So just keep an eye out on the most recent data, but it is definitely looking promising. Other adverse effects that were reported, so nausea, diarrhea, some insomnia, headaches, weight gain. So weight gain, actually, unfortunately, I couldn't put it into the slide, but weight gain was something they identified in the advanced study with Professor Francois Venter. And him and Dr. Gary Martins have recently released a paper about the weight gain that they saw. And I've only just skimmed over it, so I'm not an expert on it, but it appears what they saw, they seem to think that efavirenz, because we have so many slow metabolizers of efavirenz in the African population, that the efavirenz was actually hindering weight gain. So patients weren't actually gaining weight because they were having toxic levels of efavirenz, as opposed to dolutegravir actually causing weight gain. So I'm happy to share that paper at the end of this talk, but I only got it this morning. So just shows you how quickly the data is changing. And just to show you how rare these side effects have been. It's not to say that we won't see them. And at the end of this talk, I've also included the adverse drug reaction form. So if you are seeing patients who are having adverse drug reactions, it's really important that we collect that data. We have the biggest ART program in the world, and we're bound to see the red herrings and the pink canaries with purple polka dots. So please, if you identify them, please complete the forms that I'll show you at the end of this talk. What else does dolutegravir do that is a bit confusing for us is that it causes a benign increase in creatinine levels. And why is that concerning? Well, why is it worrying? It's not because it causes any renal dysfunction. So the increase it causes is because it decreases tubular secretion of the creatinine. Now, I'm not a nephrologist, but it actually doesn't cause any renal damage. So there is no contraindication to using DTG, even in patients who have renal impairment. The challenge is we're using DTG with TDF. So when we see an elevation in creatinine, how do we now differentiate? Is it a benign increase, or is it actually perhaps tenofovir toxicity or other causes? So the increase we see from DTG, it's usually less than 15%. And I think the key thing is that it stays stable. So don't panic unless your eGFR is dropped to like 10. Repeat it and just see if it has plateaued. If there's a massive jump, or if they're continuing to climb, then it's pointing to something else. And that doesn't mean you need to stop the DTG. You're probably going to need to stop the TDF and then investigate for any underlying pathology. I think it's really important to bear in mind that although TDF does cause renal toxicity, in my experience, there's always a different underlying cause. So even though these patients need to come off of TDF, perhaps just for a period, it's really important to find the underlying cause. I've seen several patients who've actually had renal TB who are having an iris, and that's what's caused their creatinine levels to rise. But no one bothered to look for it because they just blamed the TDF. So just be aware of that as well. Our drug interactions. So we've mentioned rifampicin. There are a few anticonvulsants to bear in mind. So phenytoin is just not a good idea with any ARVs. It interacts with efavirenz as well. So our choices for patients on ARVs would probably be sodium valproate, which thankfully doesn't cause an interaction. We used to think that it did. If one does need to use carbamazepine, then you do need to increase the dolutegravir and give 50 milligrams BD as you would with rifampicin. With regards to metformin, it actually increases the levels of the metformin, which can cause toxicity. So if you have a patient on DTG, the maximum dose you can use of metformin is 500 milligrams BD. So just to bear that in mind. And if you have patients on higher levels of metformin, then perhaps you'd want to consider efavirenz. I'm not here to bash efavirenz. It definitely has its place in a variety of areas. And then the polyvalent cations. So this becomes important, particularly if you're managing patients, pregnant patients, because they are taking calcium, often taking magnesium, and they're also taking iron supplementation as well. So if you take dolutegravir with either calcium or iron, and you take it without food, you're going to decrease your dolutegravir levels. But if you take it with food, you're not going to affect the dolutegravir levels. So this is where it gets a little bit complicated. But also bearing in mind in pregnant women that your calcium and your iron need to be taken at least 4 months apart. Well, true in any patient. It's just this we seem to see most commonly in our pregnant patients because they're prescribed both. With regards to antacids, so this I'm talking to your Gaviscons and those sort of things. I'm not talking about your PPIs. So your lansoprazole and that doesn't affect your dolutegravir levels. It's just the antacids. And here, if you're going to use an antacid, you need to use it at least 2 hours after taking your dolutegravir dose or 6 hours before taking your dolutegravir dose. So these are the suggested schedules that they recommend for patients who are taking both calcium and ferrous sulfate, is to take your dolutegravir and your calcium in the morning with food, take your ferrous sulfate at lunchtime, and then take your calcium again in the evening, or vice versa. So it's often difficult to remember all of these interactions, but if you can just bear in mind that dolutegravir and the polyvalent cations have interactions, then just remember to go and check for them. That's the most important part. So that's just the brief, my update about dolutegravir, and I'm aware of the time. I want to talk about patients who've interrupted treatment and who are reinitiating. So what do we do with these patients? And basically, just to summarize, if the patients are fairly stable, you're most likely going to start them on their original regimen. But you do need to find out what they were taking, why they stopped ART. I think it's really important to remember to be non-judgmental in this process, because we really want them back in care and we want to try and help them. Maybe they stopped because they were having severe side effects. And in that case, you really don't want to start them on the drug that was giving them severe side effects. The reinitiates, you would then repeat a viral load after 3 months. If their viral load is less than 1,000, you could then offer them TLD. If their viral load is not yet less than 1,000, you would repeat it at 6 months. If they are then less than 1,000, you could change to TLD. But if they're remaining above 1,000, then you're going to manage them according to treatment failure guidelines and most likely give them a second-line regimen. In the guidelines, they do give you a table for how you would substitute drugs if patients previously had side effects to the regimens they were taking. So the alternative to TDF would most likely be abacavir. So that's if a patient had renal toxicity, for example. If patients had issues with abacavir, so abacavir hypersensitivity or hyperlactatemia, which is extremely rare, but you could then consider AZT or TDF. If patients had, let's say, develop a severe anemia, I've seen patients with GIT upset to zidovudine, and actually I have to complete an ADR form that's an adverse drug reaction form for a patient from last week who wasn't tolerating the AZT because of the GIT side effects. Here they say discuss with an expert, and that's purely because AZT is most likely used with second-line regimens. So they've probably previously failed a regimen. So you just want to be aware of what you're substituting, that you're not creating an inferior regimen. Patients who are on dolutegravir and for some reason can't tolerate, again, I had a patient last week, my first one on dolutegravir who didn't tolerate it, and she actually had a strange side effect. She has joint pain, so I need to complete another adverse drug reaction form. Those patients you could consider efavirenz. If patients had severe side effects to efavirenz, you would then consider dolutegravir or lopinavir-ritonavir. If patients are on lopinavir-ritonavir and they get, GIT side effects or dyslipidemia, you could consider atazanavir-ritonavir or dolutegravir. Again, they say discuss with an expert, purely because in most cases, especially in adults, your PIs are second-line regimens. So you want to make sure you're giving them an effective regimen. And nevirapine, well, basically no one should be on nevirapine anymore, and just about any option is an alternative to nevirapine. So you have efavirenz, dolutegravir, or a PI. Okay, sorry to be rushing so fast. I hope I haven't lost anybody along the way. Monitoring on ART. So this is just a quick table to show you what the routine monitors are. So we're all, clinicians, and when you see patients, if there's a clinical indication to do another test or to do a test more often or sooner, please do so. But this is just what we consider routine. So remember, we've spoken about your baseline. They get a creat if they're going on to TDF, and they get a CD4, and one may argue that they should get an HB or a hepatitis B. If you're on TDF, you need your creatinine done at baseline, month 3, month 6, and at year 1, and then annually. Your CD4 count is done at baseline and then at year 1 for everybody. Then you would only repeat it if it's clinically indicated. And then your first viral load only happens at 6 months. So everyone gets a VL at 6 months. And even if that VL is suppressed, they get one at 1 year. And then they fall into their annual monthly blood. So our patients, we call it cohort bloods. Their annual cohort bloods are due in the month that they were initiated on treatment. Otherwise, according to the computer systems, their viral load hasn't been done. So you've got a bit of leeway, 3 months before, 3 months after that month. But just bear that in mind, that if you've ended up repeating viral loads because of virological failure, be sure that they end up back in their cohort. And then the change we mentioned earlier was that there's no baseline cholesterol triglycerides, but that is done at 3 months. Okay. What changed in viral load monitoring? So the definition of suppression changed. So it used to be less than 400 copies, and now it's less than 50. And basically, any patient with a viral load more than 50 needs to be treated urgently, and we need to do a thorough assessment for them. How do we repeat our viral loads? If the VL is, I see raised hands. I do have the chat box open if anyone's got questions that we can discuss as we go. Otherwise, we'll have a bit of a discussion at the end. So any viral load above 50 is going to be repeated in 3 months, but you need to do an assessment. And what's really nice in the new guidelines is they've given guidance on how to do this assessment. And it's summarized nicely. So you're going to look at the A, B, C, D, E. So A is adherence, anything that's going to affect your adherence. B is for bugs. So you're looking for any intercurrent infections. C, you want to make sure they're on the correct dose. So this can be a big problem for children and also for patients who are where you need to manage drug interactions. So if they're on rifampicin or other medications. D also falls under D, would be drug interactions. So make sure we're managing those correctly. And then lastly, you're also going to think about resistance. Okay, so don't have time to go through everything in detail, but these are all the things you should be working through in your mind when you're seeing a patient with a viral load above 50. Once you've repeated that viral load, if they stay between 50 and 999, you may want to discuss with an expert, because we could, especially if they're on an NNRTI-based regimen, because we would most likely recommend a Dolutegravir-based regimen for those patients. If the viral load remains above 1,000, then we start, we're thinking about treatment failure. But what has now become confusing, perhaps, is the definitions of treatment failure. And that's going to depend on what regimen you're on. So if your patient is on an NNRTI-based regimen, so that's an efavirenz-based regimen, you would consider that treatment failure if they've had 2 consecutive viral loads of more than 1,000, at least 3 months apart, and you've addressed the adherence issues, okay? So that's when you would consider changing them off an NNRTI-based regimen, because we know it's got a low barrier to resistance, and we also know there's a lot of transmitted and baseline resistance to our NNRTIs. If, however, patients are on an integrase strand inhibitor, like Dolutegravir, or a PI-based regimen, these drugs take much longer to develop resistance, at least 2 years, unless they've been used with TB treatment and it hasn't been managed appropriately. But these cases, you would only consider a failure or switching the patient if they've had at least 3 viral loads above 1,000 over a course of 2 years, or they've got a high viral load with immunological or clinical failure. So your definition of treatment failure is now dependent on which regimen that you're taking. So how do we decide which regimens to take? Oh, sorry guys, the time is too short for this topic. So this is the adult guideline. And I'm just going to zoot through. So if patients are on an NNRTI-based regimen, most likely it's going to be TDF, FTC, and EFE. We don't need to do a resistance test, but we do need to establish the hepatitis B status. And that's because we may be taking them off of TDF, okay? Then you have options for if they're hepatitis B negative or hepatitis B positive. I'm going to go into more detail about that shortly. If they're on an INSTI-based regimen, and they've, remember, they now need to have been failing for more than 2 years, we would love to do resistance testing, but in the adult program, there's just, the burden is too heavy. But you may want to discuss with an expert. But PIs remain an option for them if they fail. And then if you fail second-line regimens, so if you're failing DTG as part of a second-line regimen, then you do need a resistance test. But if you're failing it as part of a first-line regimen, then you don't need a resistance test, okay? The pediatric regimens are similar, except here, instead of considering hepatitis B status, we are considering their weight. But I'm going to come back to try and unpack this a little bit. I first want to explain to you what is used to guide these decisions. And I think this is really going to clear it up if there's any confusion. So the first study that's really important to know is the EARNEST trial. And it stands for East African something, I can't remember, but it was a very big trial done. And basically they compared 3 arms. They compared, and it was looking at second line therapy, so patients who failed mostly TEE, and then they randomized them into 3 arms. The one arm got Dolutegravir plus a PI. The other arm got our standard second line regimen, so 2 NRTIs plus a PI. And then the third arm got PI monotherapy. So you'll see the monotherapy performed poorly and at 96 weeks was discontinued, but the other 2 arms actually performed much the same, despite the fact that there was a lot of resistance to the NRTIs, and essentially the NRTIs were basically recycled, okay? So what do we learn from EARNEST? Is that basically our 2 NRTIs plus a PI is really effective in terms of viral suppression, and it's much more cost effective than the alternative they were suggesting, which was Dolutegravir and a PI. We saw that 2 resistant NRTIs plus a PI is really effective. But we did see that the lopinavir-ritonavir monotherapy performed really poorly. So what this means is that even though the NRTIs may be resistant, they clearly need to be there. And what this also shows us is that we don't need routine resistance testing if we're going to be using a PI regimen, because we know we can use any NRTIs with an active PI and it will work. So that's what we learned from EARNEST. The second study is to be aware of is Dawning. So Dawning was also a second line study, but basically what Dawning showed us is that Dolutegravir monotherapy causes resistance. And what we do know at that point that it works really well with at least 1 active NRTI. So here, when we want to use DTG, we want to make sure we've got an active NRTI. And basically, once you understand those 2 concepts, it helps you navigate through what we would recommend as a second line regimen. So if you look at our NNRTI-based regimens, if you fail TDF, FTC, and efavirenz, you could use AZT, because we know AZT will be active, 3TC and Dolutegravir. But in that case, they would need to be hepatitis B negative, because otherwise you would need to you would need to include the TDF. So if a patient is hepatitis B positive, you could use AZT 3TC DTG, and that's just because the DTG needs the active AZT, but you would need to add the TDF to keep the hepatitis B under control. Alternatively, you could just recycle the TDF and use it with lopinavir-ritonavir, because EARNEST tells us that that is okay. All right. Again, with our INSTI failures, if they are hepatitis B negative, you could then go to AZT 3TC lopinavir-ritonavir. If they're hep B positive, you would just recycle the TDF with lopinavir, ritonavir. All right, and basically any second-line failures, if it's lopinavir, ritonavir, or DTG, is going to need a resistance test. And if there is resistance to either the INSTIs or the PIs, you're going to need to apply to the third-line committee. Please bear in mind that if you want them to check the INSTI resistance, you need to request it separately. Routinely, they will do NNRTIs. Well, they'll do the integrase. They'll do the reverse transcriptase mutations and the protease mutations. They won't routinely do the integrase mutations, so you need to specifically request that. When we break down the pediatric regimens, so the same concept of earnest and dawning apply, but now you've got a weight consideration, because remember, we can only use dolutegravir from 20 kilograms. So if you have a patient who's failed an NNRTI-based regimen, you don't need to do a resistance test. If they're less than 20 kilograms, you don't have a choice. You're going to have to go with a PI until they're more than 20 kilograms. And then it doesn't matter which NRTI you choose, and that's based on earnest. If they are more than 20 kilos, you could then go for 2 NRTIs plus dolutegravir, provided you've got an active NRTI. If you're not sure, and that's again based on dawning, if you're not sure about the NRTI activity, then you would rather use any 2 NRTIs plus a PI. If you have patients who are failing on a PI regimen or an INSTI regimen, you need to do resistance testing. So we do that for pediatrics. And if there's no resistance, again, it's going to be dependent on the weight of the patient, whether you continue with your PI, or you could perhaps consider DTG, provided you've got an active NRTI. It's important to bear in mind here for adolescents, because many of our patients will be on abacavir 3-TC efavirenz, because that was the standard regimen. If they fail that, the vast majority of patients, if you fail abacavir, are not going to develop K65R. It's a very small percentage that develop that mutation, and that is the mutation that takes out TDF. So in the guideline, it does state that if a patient has failed abacavir 3-TC efavirenz, they could use TDF 3-TC dolutegravir or TLD as a second-line regimen, because we expect the TDF to be active in the overwhelming majority, like 95% of cases. So in those patients, TLD can be used as a first or a second-line regimen, because if they're suppressed on abacavir 3-TC efavirenz and they meet the criteria for TLD, you can transition them. But if they're unsuppressed, you can transition them anyway, because this will then become their second-line regimen. So I hope that's clear. But do we have some new data? And again, we do have some new data. And this was recent. So there's a bunch of studies going on looking at DTG with 2 resistant NRTIs, which is a similar study design to what they did with earnest. But the NADIA study results were presented at CROI this year. And basically they had 3 arms. They were comparing second-line regimens of 2 NRTIs plus DTG versus 2 NRTIs and once daily darunavir, which is a drug, it's a PI that we use in third line. And then within the DTG arm, they randomized that some got TDF 3-TC and others got AZT 3-TC. And basically the DTG and the darunavir arms performed the same, so there was non-inferiority. And the TDF and the AZT arms within the DTG arm also performed the same, despite there being quite significant resistance. So just to highlight what that means is that the DTG plus 2 NRTIs gives excellent viral suppression, even if the NRTIs had no predicted activity. But there were cases of high-level DTG resistance. So this is still an approach with caution, and we're still waiting for more data. This is only 48-week data, okay? And that the TDF 3-TC performed well even in patients who had K65R or M184V mutations. So the take homes from here is that it was just a very brief presentation. So it looks exciting for us, because if we could recycle our TDF, that would really be exciting. But the study is powered for 96 weeks, and so far we've only got data from 48 weeks. We're still waiting for results from other trials. So it's too premature to change the guidelines at this point in time. So in most cases, you still want to rely on that active NRTI. But if you have a situation where you don't have other options, so my patient who wasn't tolerating AZT, I did recycle the TDF based on the data that we're seeing so far from NADIA. Sadly, from a pediatric perspective, we only have data on TDF and AZT and nothing on ABC. And for now, we just need to wait for more data, but it is exciting what we've seen so far. Okay. Please identify treatment failure early and manage appropriately. So this was a study that was done a few years ago in South Africa. And this was, based on patients who were failing TEE. So remember, low genetic barrier. And you define treatment failure with 2 consecutive viral loads above 1,000, more than 3 months apart. And only 41% of patients were actually switched to a second-line regimen. And the median time to switch after detection of virological failure was 59 weeks. So it takes people more than a year to change people off of a failing NNRTI-based regimen. And that's really devastating because, it causes immunological and clinical failure. It results in mother-to-child transmission. Our patients get sick. You accumulate resistance. We, transmit resistance. So it's really, they're really serious consequences of delayed switching. And lastly, we're getting towards the end. I'm sure you're tired of my rushed voice. I just wanted to talk about the other drugs and bugs. So what were the updates about Bactrim prophylaxis? So children under the age of 1 year, that has stayed the same. They all need to be on Bactrim irrespective of their CD4 percentage. Children between the ages of 1 to 5, that's also stayed the same if their CD4 percentage is less than 25%. And then patients from the age of 5, if the CD4 count is less than 200, they need to be on Bactrim. So that's what's changed. The previous guideline used to say 350. And what else is new is that you can discontinue once you've had one CD4 count above 200 or above 25%, depending on the age group. TB preventative therapy, or TPT, there's a lot of resistance to TPT, and I find it particularly with doctors. I'm not entirely sure. I know people are concerned about developing INH resistance and perhaps about hepatitis, but there really is a lot of data available. This is a meta-analysis on the Cochrane database, and there's also the Temprano trial, which really shows that it significantly reduces the risk of TB, and it actually saves a lot more lives than the potential. So the benefit of saving all these lives against the potential risk of developing resistance and the few patients that might develop a hepatitis, the pros really outweigh the cons in this scenario. Unfortunately, we don't have time to go through all of this, but what has changed again in terms of TPT is in pregnancy. So all pregnant patients who are positive get a TB screen. Irrespective of that screen, they get a gene expert. And if their screen is negative and their gene expert is negative and their CD4 count is less than 350, those patients get IPT. If their CD4 count is above 350, you're going to defer IPT because the risk-benefit ratio doesn't work out. We are seeing some adverse outcomes, pregnancy outcomes, if you're using it at higher CD4 counts. So we want to use it at lower CD4 counts where the risk of the benefit of preventing TB is greater than the risks that we're seeing. Okay, so that's what's changed in terms of IPT. So that just shows you, so who is eligible in terms of pregnant women is if they have a negative screen, negative gene expert, and they have a CD4 count less than 50. If their CD4 count is more than 350, you're going to defer until 6 weeks after they've delivered, and then you're going to start their TPT. In children, please don't forget about the children. We need to screen children for TB at every visit, and this should include a TB contact, okay? And when you're managing TB patients, make sure you check if there are any children at home. And then you want to screen them for symptoms. If they have a positive TB contact, so children don't routinely get IPT. It's only if they have a positive TB contact and they've got no active disease, then they get IPT for 6 months. This is true in all children, irrespective of HIV status, if they're under 5 years of age. And it's in all HIV positive children up to the age of 15. So any child under the age of 5, irrespective of their status, and then HIV positive children up to the age of 15. The dose is 10 milligrams per kilogram of INH and pyridoxine, and you repeat it with each TB exposure. So it's very much a post-exposure prophylaxis in children. Okay. Whereas in adults, it's sort of a once-off. And we're nearing the end. I do apologize for going over time. What has changed in terms of cryptococcal disease? So, as we've mentioned, the lab will routinely do a reflex CRAG when the CD4 count is less than 100. If it's negative, or you can happily start ART. If it's positive, these patients should really be referred for a lumbar puncture. Even if they are asymptomatic of meningitis, the study at Helen Joseph found that more than 30% of patients who were asymptomatic actually had confirmed cryptococcal meningitis on LP. So they should be referred for an LP. If the CSF is negative, then you're going to start fluconazole. And let's see what has changed here. The induction phase is 1200 milligrams daily. It used to be 800. It's now gone up to 1200 for 2 weeks. And then it's going to come down to 800 milligrams for 2 months, and then going to fall into the maintenance phase of 200. Okay. You can start your ART after 2 weeks in the LP negative category. If the LP is positive, then they're going to get their IV amphotericin B. They obviously need to be in hospital, as well as high-dose fluconazole, 1200 milligrams. And then the consolidation phase and the maintenance phase remains the same, except you're going to defer your ART for 4 to 6 weeks. Just remember, we're worried about an iris. Okay. And then just some practical resources just to end everything off. This is the adverse drug reaction form. It's available on page 61 of the consolidated guidelines. I have 4 patients that I need to complete for. So 1 for AZT, 1 for Illuvia, and 2 for TLD, and need to submit that. So they do provide that email address on the form. However, in COJ, if you're in Johannesburg, please email the email addresses listed over there. They consolidate and then submit the report to the Department of Health. So we really have a responsibility now that we've rolled out a new drug to make sure that we're recording these things accordingly. The next one is the Liverpool Drug Interaction website or app. So no one can know all the ARV drug interactions. It's simply not possible. So if you have access to a computer, you can simply Google it, or you can download the iChart app on your smartphone. And it's a really great app. That's what it looks like on your phone. And you select all your HIV drugs, you select all your co-medications. Please remember that it's the generic name, not the trade names. And then it's going to give you all your interactions. And once you click on that interaction, it's going to tell you what to do about it. So this interaction is dolutegravir rifampicin, tells you there's high quality data, it reduces the dolutegravir, and that you should add an additional dose of dolutegravir. So it's a really great app to have and to go through if you've got HIV positive patients, if they're on polypharmacy and you know, they've got lots of medications. And if you want to add something new to just check. It's a really great app. It includes over-the-counter medications and herbal stuff. So it's a really cool app to have. And that is the end of my whole long spiel. And I just do have some acknowledgements. So the Department of Health and the National Consolidated Guidelines, the South African HIV Clinician Society, Dr. Leon Levine let me use some slides, Dr. Jeremy Nell also lent me some slides, Dr. Ninka Fari and Niradzo from Inova. So just wanted to acknowledge them. And I'm at the end, so let me just stop sharing so I can see if there are any hands. Thank you for giving me your extra 5 minutes. I don't see any questions in the chat box, but I do see some hands up. I don't know if they are real hands. So can you guys unmute yourselves and ask your question, or do I need to unmute you? Looks like Lebogang and Joseph have their hands up. Ebocha? Okay, sorry guys, has anyone got any questions? I know I rushed through that. I was just trying to get through in our allotted time. No questions. Okay, I see Gugu has got a new hand. I'm just trying to see if I need to unmute you, or can you unmute Gugu?
Yes, I've had a woman. Yes, afternoon. I've had a woman, a pregnant woman. Yes, I TEE previously, and then she was switched to DTG. Then
yeah,
found out she was pregnant. She was switched to the DLTG prior to pregnancy, and then 2 months after she found out she was pregnant, and then they switched her back to TEE. So when she comes in for booking, do I leave her on TEE or do I switch?
It's a very good question. So, you know, I think as the data is coming in, I mean, just initially, generally when patients find out that they're pregnant on TLD, they're beyond that 4 to 6 week period for the neural tube. So is there any benefit in taking them off? Probably not, unless you're really convinced it's early pregnancy. And number two, the data we're seeing from the TIMEFRAME study is, you know, leaning towards perhaps that's not necessary, but it was recommended in the guidelines. So now the switch has happened and we now need to decide how to move forward. Gugu, what I would do is probably keep her on it if she's tolerating it, and just check what her viral load's doing, and then bring her back to get her viral load results. And if she's still suppressed on her TEE, I'm inclined to leave her on what she's comfortable and what she's suppressed on until the baby's
she was
out.
TEE.
Yeah, so if she's suppressed on TEE, continue and just see what her viral load does. Thanks, Gugu. Cool, guys. Are there any other questions? I wanted to actually share my, let me just share some resources or some contact numbers for you guys. Sorry. If you do have any questions, you're welcome. I'll put it in the chat. How's that? If you guys ever have any questions, you're welcome to give me a call or send me a WhatsApp. So I've just put my contact number in the chat and my email address. And alternatively, if you can't get hold of me, oh dear, sorry, I'm sending it to the wrong people. So sorry, so there you guys should be able to see it. That's my contact number. And my email address. And alternatively, Right to Care also has a helpline, largely pediatric and adolescent. But if you can't get hold of me, you're welcome to give them a call as well. I just want to get the number for you. And yes, that's all. So hopefully you guys found that helpful. I felt a bit rushed, and I really hope we'll get an opportunity to do PMTCT, because that's a whole lot of other stuff as well, which unfortunately we didn't get to today. So that's the Right to Care helpline as well. So thanks everybody. I hope to meet you all soon, and thank you for attending, and feel free to get hold of me. Bye.